Hello, my name's Laura Coates, a rheumatologist, and I'm coming to you today from Oxford in the UK. I'm going to speak about one aspect of what the future might hold for psoriatic arthritis, and that's particularly thinking about precision medicine or personalised medicine and how that might change the way we treat people with psoriatic arthritis in the future. So I think it's important to acknowledge that we already do some form of personalized medicine, and that's what you do every day in your clinic with the patients that we see. It's pretty much impossible in psoriatic arthritis to write a single flow chart for the best way to treat somebody with psoriatic arthritis. And so we take the data that we do have and distill that down to pick the best drug for each patient day to day. So in clinic at the moment, I'm thinking about which domains the person has active in terms of their psoriatic arthritis. Do they have axial disease? Do they have significant psoriasis or nail psoriasis? And that might help me to choose a therapy that's effective in those particular domains. We all think about comorbidities. This is something that's key for a lot of our psoriatic arthritis patients, both in terms of related conditions like uveitis and IBD, but also other comorbidities like liver disease, obesity, and cardiovascular disease. So these things we already take into account, as well as access and patient preference. But we're in this situation where we really have an embarrassment of riches in terms of the treatment of psoriatic arthritis. We've got increasing data for conventional DMARDs, and we've also got an increasing number of both biologics and targeted synthetic DMARDs that we have to choose between for each patient in front of us. And really, at the moment, we rely on a trial and error approach. We try the drug that we think might be best, depending on their domains and the access that people have to therapy. But then, if that doesn't work, we're usually waiting 3 to 6 months to measure response. And then we're having to switch to another drug and wait another 3 to 6 months to see if a patient will respond to a different drug. And obviously, in some other specialities in medicine, the idea of precision medicine or targeted therapies has really changed over the last decade or so, such that this has become a reality in the clinic. If you think about patients with cancer undergoing treatment, it's now very typical that patients will have a biopsy, will have a number of markers looked at in that biopsy of their tumor, and will then have an appropriate drug matched to them because of that biological pattern of disease. And so this is something that we think may hopefully come in the future in psoriatic arthritis, and something that's already generated some early research. So we know that psoriatic arthritis is heterogeneous. We've got patients with very different aspects of disease. It seems likely that they differ somehow on the pathogenesis as well. There has been one small study to date looking at precision medicine with biologics, and that was run in Japan. And they sorted patients either into a standard care group, where they underwent biologics as chosen by them and the patient that they were treating, or a precision medicine approach, where they took peripheral blood, did lymphocyte phenotyping, and then tried to match the particular biologic to the pattern of lymphocytes that was identified on those samples. So they split people into 4 groups based on Th1 and Th17 proportions, and then matched them up to the individual drugs. And what that meant in terms of prescription was that in the standard care group, the majority received TNF, which I think would also be our practice as well. But in the precision medicine group, there was a shift to around half the patients receiving IL-17, and then the other half receiving mostly TNF or a few with ustekinumab. Now, this study was small, it's highly likely to be underpowered, and there was no pre-specified primary outcome. But they did see across a number of musculoskeletal outcomes a benefit in terms of treat to target, some of which seemed significant, although with multiple testing that's a bit difficult, but the majority of which seemed to be in the right direction, favouring precision medicine. I think it's unlikely that just the Th1 and Th17 proportion is the magic test for psoriatic arthritis. We've got such a heterogeneous condition that I'm sure it's going to come down to more than that. But we have seen positive data in other rheumatological studies looking at a number of different biomarkers in peripheral blood, some also in biopsy samples from joints as well, but starting to suggest that we may be able to target therapies to particular individuals. And that's something we're lucky to be studying at the moment in the UK. We're recruiting a study using that same Th17 marker and stratifying patients either to TNF or IL-17 therapy, but also, I think importantly, doing a number of additional tests on those peripheral blood samples, looking at intracellular cytokines, looking at RNA sequencing, and RNA sequencing in specific cell subsets. So we're hopeful in the future that our study and other studies will enable us to do a baseline blood test and then predict a drug that at least has a higher chance of response and or a lower chance of side effects, so that we can start moving towards a precision medicine approach in psoriatic arthritis.